This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
In this video, we'll see how I performed a manual small incision cataract surgery by choice and put in a toric intraocular lens implant in a patient who had a very dense cataract with questionable zonular health. So she is an 82-year-old frail lady who has this hypermature cataract. We can see the calcific specks on the endocapsule. The underlying nucleus seems to be very dense. It looks to be brown, and the point to consider phaco versus SICS, she has a pre-existing astigmatism of 1.5 cylinder against the rule. And in our center, usually we put in a toric lens for every patient who is having 0.5 or above against the rule astigmatism, and this patient definitely fit in that category. And we have already got the toric lens in place. But looking at the cataract and the general health of the patient, I was not sure of doing phacoemulsification simply because my major concern was the zonular health in this patient and also looking at the density of the nucleus combined with a weak bag. So I was not sure whether the phaco was the safest option. So I decided to do manual small incision cataract surgery. And when you want to do a manual small incision cataract surgery, what is the location which you would want to choose? Now, typically, most people in India and worldwide would do it in the superior quadrant or in the superior temporal quadrant. But if you want to have the least amount of surgical induced astigmatism, now doing a temporal incision is the best way. So, in my experience, even an incision of about 6.5 millimeter would not give an astigmatism more than 0.5. So, if you're planning something like a toric lens where your surgically induced astigmatism has to be very controlled, then obviously you have to choose the temporal incision itself. And that's the reason why I'm going to do a temporal MSICS in this patient. Let's see how it is done. I'm sitting temporally. The surgery is being performed under a perivalvular block. There is no superrectus traction suture put. The conjunctival peritomy is performed using the scissors and the Hoskins forceps. The superficial episcleral tissue is scraped off using the 15 number blade, and then a gentle cautery is applied to the bleeders. Mind you, we need to avoid excessive cautery. Just identify the bleeder vessels and cauterize them individually rather than doing a carpet bombing like cautery throughout. So to stabilize the globe, I prefer to use a posterior scleral incision, which is about 2.5 millimeter in width. And it is placed exactly about 2 mm from your originally planned scleral incision. So I'm stabilizing the globe using this scleral groove with a limbs forceps, and a 7 mm long scleral incision is created, which is slightly frown in shape. The central portion is about 1.5 mm from the limbus. Using a crescent knife, the corneal scleral tunnel is being performed now. And as I venture to the left side, we can see that the groove has been much more superficial than what my tunnel is. That's the reason why you have this shelving of the sclera which is happening. The solution is come out and deepen the scleral groove, and then you continue with the tunnel. The same tunneling is continued on the right hand as well. It's important to understand the concept that the extension of the tunnel into the cornea is critical. We need to have the inner lip at least 1.5 mm from the limbus, and it has to be in a curvilinear fashion. The internal incision always has to be like a smile with at least some amount of corneal tissue away from the limbus until the peripheral part. This concept has to be clearly understood because the presence of this internal corneal tissue throughout the entire span of the incision is the one which ensures the valvular nature or the self-sealing nature of this corneoscleral tunnel. So avoid making the incision running towards the limbus in the peripheral part. At least some amount of corneal tissue has to be there between the limbus and your internal incision. The side ports are made, the capsule is stained under the air bubble, viscoelastic is placed inside the antechamber. And now is the time to perform the entry into the antechamber through the scleral tunnel. I prefer to put in viscoelastic in the tunnel so that it just lifts up and guides my blade nicely, and I can go and visualize the far end of the internal lip, before which I am going to perforate the descendants and enter into the antechamber using the 2.8 mm keratome. While extending laterally, the edge of the blade is slightly tilted upwards as the extension of the internal lip is being done on either side. Now we have our internal lip, which is nicely done. Time to perform the rhexis. So as I puncture the anterocapsule, we can see that the lens is wobbly, the flap is raised, and as I begin to tear, I also realize that the capsule is extremely fragile and thin, so it has a tendency to tear off. Nevertheless, the rhexis is begun. An important consideration here would be to have an adequately sized rhexis, simply because the underlying nucleus is quite hard, and I don't want to cause any trauma to the bag while maneuvering the nucleus. Ideally, if you're planning a toric lens, the rhexis has to be around 5 mm, but this is a special situation where I don't want to compromise or sacrifice any zonulus of the capsular bag. So I want to preserve the bag first, so that at least I can put the lens inside. So rhexis is done. Time to perform the hydrodissection. It has to be very gentle because there is hardly any cortex. We just want to break any cortico-capsular adhesions, which will be very common in these long-standing hypermature cataracts. Decompress the bag. Chamber is filled with OVD using 2 Sinskey hooks. The nucleus is wheeled out of the bag using the bimanual wheeling out technique. The dialer goes in and hooks the equator under the surface of the nucleus, and then the other one just rotates or wheels the nucleus out of the bag. So now we have the entire large brown nucleus in the antechamber. Again, I was very generous with my wound construction simply because I was expecting this large and bulky nucleus. I don't want to struggle anywhere while extracting the nucleus, simply because these old patients are very vulnerable for endothelial damage, descendants memory detachment. So nucleus delivery has to be as gentle and as uneventful as possible. My preferred technique is the phaco sandwich technique. The dialer goes in first, followed by the vectis. The dialer compresses the nucleus down so that it is squeezed in between the vectis and the dialer, and the entire complex is now pulled out of the eye. So the nucleus extraction was quite easy and safe, primarily because of the bigger incision which we had created. The cortex needs to be removed. Now, in these long-standing cataracts, the cortex will be very peculiar in the sense it will have very few cortical fibers, but it is a pain to remove them simply because they'll be sticking onto the capsule very strongly, and I'm just irrigating out to loosen up these fibers. And invariably, when you're trying to be very meticulous and trying to aspirate these cortex, there's always a risk of either causing zonular dehiscence or a PC tear. So this time I'm reminding myself that I need to be mindful not to overdo with the cortex extraction. Gently but surely, most of the cortical fiber is pulled out. Now is the time to implant the lens. The bag is filled with OVD, and in this case I'm going to use the cartridge and the injector system itself to place the lens inside. Of course, we can just insert the lens using a forceps as well. In these foldable lenses, some of them, sometimes I feel it is better off to implant them with the injector itself, because they are not so rigid, and manipulating the haptics inside the bag can be tricky, unlike a rigid lens. So there's a reason in this case I'm consciously using an injector to do the job for me. The chamber is again inflated with OVD, and the trailing haptic is dialed into the bag. Time to remove the OVD. I prefer to always use just the irrigation to flush out all the OVD, both in front and behind the lens. And then the time to orient the lens along the axis. Using the irrigation cannula, the lens is gently nudged and brought near the axis. I felt the alignment of the lens was good enough, so I didn't want to go in and again rotate the lens. The side ports are hydrated. Time to close. The conjunctival flap is reposed back, and both the ends of these conjunctival flaps are cauterized so that it sticks well. And that's it, the case is done. So let us see the refraction after 1 week. And this is the post-op pictures of 1 week. The patient is doing well. And the autoref reading shows is plus 0.5 spherical and minus 1 cylinder, 85 degrees. And she accepts about minus 0.5 cylinder, 90 degrees. And she reads 6 parts. So this was quite a good outcome in this eye. Although there is a minus 0.5 cylinder residual, well, it's okay. To summarize, so this case just highlights that if your wound construction in SICS is appropriate, you can get a predictable surgical induced astigmatism, and then you can go ahead and plan with a toric lens as well. So in such complex cases, you can still give the patient the best refractive outcomes even with manual small incision cataract surgery, without compromising any of the safety measures. That was it. Thank you for watching and hope you found this helpful.